Okay, our third speaker today is a medical director, a professor of medicine, and a consultant with the Division of Pulmonary Medicine and Internal Medicine with the Mayo Clinic in Jacksonville, Florida. In addition to many other awards, he has been listed in Best Doctors in America for 12 consecutive years. He specializes in critical care medicine and has experience in surgical procedures, respiratory tract diseases, lung transplantation, COPD, and more. Here to discuss with you how to prepare mentally and physically for lung transplant, please welcome Dr. Cesar Keller.
Thank you very much. I asked them to dim the lights a little bit so the images can be seen better, and if somebody wants to take a nap, then it will be even easier. So, and as a resident from Florida, I want to welcome those that are not from Florida. Enjoy the amenities, but be careful. Sometimes it can get tricky. I was asked to talk about how to prepare for a transplant. And I think it's a topic that is really important because when it comes to transplant, you can apply that old saying, I think it's attributed to Benjamin Franklin, that failure to prepare is a sure preparation for failure. And that is certainly very true for transplant. This is the famous thinker. I think he had emphysema. You can see his lungs with emphysema there. And I'm sure he was thinking about whether he should have a transplant, if he will have one, would I survive the transplant, where will I go with this transplant, what testing do I need to do? So many questions that come about, will I be accepted even for a transplant? These are a lot of questions that come along. And certainly, I'll try to address most of them, and I'll try to give you my insight on how to prepare for them. Those black question marks were not supposed to be there, but sorry. So I'm going to divide the preparation talk in these main issues about, prepare your mind first. I mean, if you live with a chronic disease, at some point in time, the question may come about whether you really want to face a transplant. And then I'll try to talk later on about how to prepare for the visit to a transplant center, how to prepare for a lung transplant evaluation, how to prepare for the entering of the transplant list, national transplant list, what to do during the waiting time, and how to prepare for the actual day of transplantation. So I'll start first with the initial preparation of your mind. And obviously the question will be initially, if I live with a chronic disease such as emphysema, is it a reasonable thing to think that at some point in time I may need a transplant? And there are many indications for transplantation. In basically any chronic disease for which there is no cure, if that disease enters a late stage where either will disable you or it will compromise your survival, certainly transplant becomes an option. And these conditions here, COPD or emphysema, cystic fibrosis, pulmonary fibrosis, and pulmonary hypertension are the four most common causes of transplantation. Not the only ones, but the most common ones. In fact, if you look at this data that has accumulated in these registries, an international registry where more than 30 transplants have been accumulated in this registry since 1989, you can see how the distribution of transplants are according to frequency and incidence. And if you look at pulmonary hypertension and retransplantation, that accounts for a very small amount of transplants and has been the same throughout the years. And COPD and alpha-1 obviously together account for one of the largest majorities of the indication for transplant. But the indication that lately, probably as a result of the long allocation score that Dr. Zamora is going to address later, the group that is growing the fastest is the group with pulmonary fibrosis. That's the main indication that is growing as the most common indication for transplantation today. This is data from this country, the United States, and you can see that the curves for COPD and for alpha-1, the frequency has been decreasing, About 1,200 transplants were reported in 2008, and you can see that about 422 was with the indication of COPD, only 43 with alpha-1. If you look at idiopathic pulmonary fibrosis, has been climbing progressively, and ever since the last few years, that's the main indication today for lung transplantation, or the most frequently, I should say. Now, when you're trying to prepare your mind to think if this will be a viable option for you, obviously the question becomes when is it reasonable to start thinking that transplant may be an option? This is a diagram that presents some obvious facts, such as if you have a disease, and let's say the survival here goes from 100% and then declines as the time goes on, and this is the disease predicted survival. If you have a disease like this, and if you will know that the survival after transplant over the next few years will be like this, obviously there will be a line of intersection where at some point in time you will have a survival advantage compared to your disease if you get transplanted. And that's where you try to sort of find that point where obviously transplantation will offer an advantage. Now, this is a set of beautiful lungs from an 18-year-old donor compared to what emphysema looks like. This is smoking-induced emphysema. As you may know, people with alpha-1, they develop all these blebs, mostly in the lower lobes. But this is how the lung travels from normality to end-stage emphysema. And this causes a lot of disruption in the pulmonary function test. How many of you guys here have had pulmonary function tests yourselves? Good. So I'm talking to a very knowledgeable audience, but basically when you are normal and you take a deep breath, you will have a very large volume that you move, the so-called vital capacity, and you are supposed to, 80% of your vital capacity should be blown out in the first second, the so-called FEV1. And you are supposed to have a very small volume at the end of a normal breath, the so-called residual volume. When you have end-stage emphysema, obviously the amount of air that you can move in and out is very small because you are trapping a lot of air, which is the residual volume, and obviously that produces obstruction in the airways and it takes you a long time to exhale. And classically, over the years, it's always been assumed that the smaller this FEV1 becomes, the more likely is that the survival will be compromised. And then in the past, that used to be the best way to calculate when to refer somebody for transplant, when to think on asking the question about transplant, and when to be transplanted. Obviously, the distress from emphysema becomes because you will have, compared to a normal lung, which has diaphragms that can move freely up and down, you have this so-called barrel-chested configuration. There's so much air trapping that you're like inflated all the time, and they ask you to take a deep breath. Well, there's just not a lot of room to go because the diaphragm no longer moves. Now, some years ago, in the New England Journal of Medicine, there was this study published that perhaps the best way to decide when the disease was advanced enough to cause compromise in your survival was combining several features, several factors. And those factors will be the FEV1 itself, and they will give you points. If it's more than 65%, no points. When it falls between 50 and 64, 1 point. 36 to 49%, 2 points, and less than 35%, 3 points. And then the points will be assigned also how far can you walk in 6 minutes, the so-called 6-minute walk test that some of you probably have had. Well, when that distance becomes less than 150 meters, that means you're very limited. And then this is a scale of, subjective scale of breathlessness, where 0 means I have no breathlessness, 4 means I'm so breathless I don't even want to leave home, I just want to stay and not socialize anymore. And obviously the worse you are, the more points you can assign. And then the body mass index was included. The body mass index is that relationship between your weight and your height. And if you are less than 21 having emphysema, that means you're starting to get in that malnourished status. So what they found was that once your body index the body index was 5, that's probably the time that it's a good idea to start the process for transplant, because the survival rate starts to be compromised 3 to 5 years later. And most likely the time to actually be transplanted is when that index reaches about 7 or 10. That means when your FEV1 is less than 35%, you are extremely breathless, you can hardly walk, and you're starting to become malnourished. Now, out of another study, some years ago, there was this big study called National Emphysema Treatment Trial to define if lung reduction surgery was good or not for emphysema. And out of that trial, it was also found that patients that have criteria that will disqualify them for lung reduction because they were too bad, i.e. the FEV1 less than 20% and the so-called diffusion capacity, which tells you how good you are oxygenating, was also less than 20%. The average survival rate, the median survival rate was only 3 years, and therefore that could be another suggestion on when the right time for transplant should come. Now, when you compare the survivals for transplantation, you can see that across the time, the numbers are getting better and better and better. And indeed, when you look at a transplant in the latter times, the half-life for transplant is about 5.7 years. That means half of the people gets to live about 5 years. This so-called conditional half-life is if you reach transplant healthy after year 1, you have better chances that your median survival will be about 7 years. Now, these are averages, and there are a lot of centers that have numbers worse than these and centers that are a little bit better than these. But most centers, as time is going on, ours included, these numbers are starting to getting better and better and better in regard to survival. And obviously, when you have a bad disease, that's a good thing to know. Now, when you look at the survival rates, specifically looking at COPD in red color and alpha-1 in blue color, you can see that, in fact, the long-term survival for alpha-1 recipients tend to be significantly better than the majority. Maybe it's because typically these patients tend to be a little bit younger than the average COPDer. The COPDer has a fairly stable, comparable survival to other diagnoses in the first few years, but as years go on, the survival rates drop. Probably because this is also an elderly population that you are transplanting. But nevertheless, when you compare alpha-1, they tend to have good prognosis after transplant compared to other diagnoses. So therefore, when is the right time? Well, here what I did is I put the transplant survival rates in the top and these body index survival rates on the bottom. And you see that when the body index is 5 to 6, and this is the blue line is the 50% mark. It takes you about 3 years to get to that line if you have a body index of 7. And at 3 years, the survival rate with a body index of 5 to 6 is going to be close to 80%. So certainly, if you receive a transplant and by your body index you are more in the range of 5 to 6, you are really not necessarily having a survival advantage by being transplanted. You may survive just as long with your disease in average. It's only when you start becoming extremely dysfunctional that then transplant may offer us survival advantages. Contrary to other diseases like pulmonary fibrosis, idiopathic pulmonary fibrosis, has a median survival of only 2 years. So when you get a transplant offers a distinct advantage in survival, but not for emphysema. If emphysema is extremely, extremely advanced and your FEV1 is getting to 10, 12%, yeah, you may have a survival advantage. But a lot of people is very disabled before they get to such a low point. And so therefore, many times, if you are to take the decision of taking a transplant because you are very disabled by emphysema, that decision most likely is because you want to change your quality of life, but not necessarily because you are going to increase your quantity of life. And we made that point very clear to all patients that come to our center seeking transplantation. So, how do you prepare for your visit? Let's say the doctor tells you, you know what, your body index is 5, you're not doing well, let me send you to a transplant center. How do you prepare to go to a transplant center? Well, you want to do your homework because you want to make the most out of that initial visit. You probably want to review the outcomes that that transplant center has, and this is a very transparent process, and I'll show you how you can do that. You probably want to think about all the questions you want to ask, because typically whatever you wanted to ask will come to your mind 5 minutes after the doctor left the room, and that's not a good thing. So it's better that you bring your question. Bring all your medication list, medications that you know you tolerate well in the past, medications that have give you trouble. That helps the physician a lot. If you bring copies of your medical records or letters describing why you've been referred for transplant, that helps a lot. If you bring reports or radiographs and x-rays and all that, that's good, but it's even better if you actually bring the CDs or the actual films so the physician can review all that for you. Your visit will be way much more productive if you prepare that way. Now, you may want to perhaps postpone or cancel your visit if there are things that flat out the transplant center will tell you that will not allow you to be transplanted for. If you're still smoking, you're wasting your time. Most centers will not accept somebody that is still smoking for transplant. And we are very strict about it. So each center has its own criteria. But if you're still depending on tobacco, that's not compatible with transplant. Same if you are depending on any other substance or alcohol. Now, if you have hepatitis B or hepatitis C with liver disease or HIV, most likely you're going to be told that transplant can't be done, and it will be a waste of your time. If you have any kind of active cancer, or if you had a cancer in the last few years and you haven't reached that magical 5-year cure period of time, that will prevent you to have a transplant. Or if you are by yourself and you have no reliable caregiver, most centers will just not move forward until you can show that somebody is there to help you in the process. Now, if you want to check the outcomes of any transplant center in the United States today, it's very easy to do. You go to this web page, and that web page has the specific reports or results of every transplant center. When you click that, a map comes along. If you click on the map of Florida, immediately will tell you in this state you have 4 transplant centers. And you can go, I'm going to go to our own program. When you click on that, you will get an 11-page summary where everything you want to know about that center is there. How many transplants they do, how many they have in the waiting list, what's their average waiting time. Of course, for your benefit, you probably want to check if that center is doing okay regarding outcomes. And you get a report. This is the report, for instance, of our center of the 1-month survival rate, 100%, 1-year survival rate, 93%, 3-year survival rate, 71%, and you get the average for the country. So you can see if that transplant center, what volume is it having, what outcomes is he having. Now, this information does not tell you everything about the transplant center. I mean, you may have a transplant center that is so conservative that he just transplants not so sick people. Well, they could have relatively good outcomes, but they are not necessarily transplanting people that is in a lot of disease. But at least you learn some information about the given center that you're going to visit. Expect on that first visit, be prepared because, all the data that you bring is going to be reviewed. There's going to be a general discussion about the prognosis, the benefits, the risks, tailored to your characteristics. All the sections of care will be discussed, and you will be given the opportunity to decide there or later if you really want to move or not with a transplant after you hear what it takes. It takes commitment, it takes to understand morbidity, mortality, and everything that needs to be done. If you wish to proceed, there is a special consent form that has to be filled out, and that will initiate the transplant workup. Now, if you are going to have the transplant workup, you have to be prepared, like brace yourselves for it, kind of. Because it's a very intense testing. A lot of testing is going to be done. And this testing is going to involve taking your history, your physical examination, doing a lot of blood work. I mean, a lot of blood work. Some people is amazed on how much blood. is taken for this test. Your heart will be tested, your liver, your kidneys, everything will be tested. Even things you don't want to be tested, they will test it for you. And you will have to stop with various consultants. You heard about how important is an infectious disease doctor. Well, you have a lot of consultants on that have to give an opinion. It's indeed a pain in that anatomical area that you know. It is not easy to go through this testing when you're, carrying oxygen and feel breathless, and some days you feel sick and some days you don't, and it's not easy. So you have to brace yourself for it. Now, a lot of the evaluation is going to involve, of course, assessment of how is the situation of your lungs. You'll have x-rays, scans to define if you have one lung better than the other, so maybe the decision of which transplant to do will be done. CAT scans will be done. This is a CAT scan here with a lot of emphysema in the upper lobes, which is typical of somebody with emphysema. This is a CAT scan of a patient that they refer to us. You'll be amazed how many patients, when they come to be evaluated for transplant, we do in all of them alpha-1 levels, and for the first time you diagnose them with alpha-1 antitrypsin deficiency. These are the CAT scans of this particular patient, smoking-induced emphysema. He did have still some viable tissue on the bottom, but look at the alpha-1 person, a lot of emphysema on the basis. You will have evaluation with pulmonary function tests, of course, and you will have evaluation, very detailed evaluation of your heart. You will have a right heart catheterization to measure your pressures and to measure your cardiac output and other numbers that have to be available. You will have a left heart catheterization to assess if your coronaries are patent or not. Many patients are, as you know, have been smokers, so there is risk for heart disease. There are things that we check that you may not think they are related, but most patients will have some kind of GI assessment to find out if they have reflux or not. Most patients, if they haven't had a colonoscopy, they will have a colonoscopy, and you may ask, well, why do they need to look down there when I need a lung transplant? Well, the reason is that the transplant medications you may need later on could induce cancer in a patient that could have a carcinoma in situ or an undetected cancer. So we have to screen these people for cancer, make sure that any polyp gets checked. For females, they'll have mammograms. The bones will be checked to make sure you don't have osteoporosis or other conditions that could contraindicate transplantation. So it's indeed, again, brace yourselves because it's going to be a very detailed testing. And then you have to be ready mentally that I went all this testing and they told me I cannot be transplanted. Because sometimes the testing, in fact, will find reason to believe that you are not a good candidate for transplant, that you may actually live longer with your disease than with a transplant. And a lot of people sometimes goes to a center and gets upset because they don't accept their case for transplant when they don't know that the team honestly believe that it's in their best interest not to be transplanted. So you have to be mentally ready for that. Typically, this decision is made by a committee. Every transplant center has one where the decision is, can we transplant this person? What kind of transplant shall we offer? Now, if the transplant team accepts the case, the patient will not yet be effectively listed. You need the cooperation of the United Network for Organ Sharing for that happening. This is the organization that has to do with, if a transplant center wants to transplant you, somebody has to give lungs to this center. That somebody will be this organization called UNOS. So the transplant process involves for the transplant center to evaluate the patient. The transplant center will decide if the transplant can occur and what type of transplant should be offered. Then you will need the cooperation of the United Network for Organ Sharing, who will actually put your name on the list with a description of what kind of donor you need and what kind of lung or lungs will you need. And that's what creates the waiting time. And depending on how sick you are, they will actually assign to you a score of necessity called lung allocation score, which Dr. Zamora will talk more about it. After that, you need another entity to help you, which is the Organ Procurement Organization. This is the organization that regionally, in every center that is a brain-dead person, they will manage and they will coordinate the surgery on this donor so the organs can become available. And then when the organ becomes available, that organ is made available to the transplant center, and that's how a transplantation eventually will take place. This is a donated lung, and he's freshly implanted here in a patient with emphysema. So that's the whole process. You need these three structures to interact very closely to make this happen. Now, in COPD, in severe emphysema, there are several options. Typically, you will have to decide whether to offer a single lung transplant. This is a patient freshly transplanted on the right side with a big emphysematous lung on the left side, and or to proceed with a double lung transplant where you change both lungs. This is how the process evolves, usually chronically with a single lung. The lung appears small. It's not small. That's normal size with a normal diaphragm. But the other lung is hyperinflated and big. Most patients with advanced COPD of advanced age will be offered a single lung transplant, which offer the advantages of shorter waiting time, less complex surgery, and is better tolerated by debilitated patients, versus a double lung transplant will likely be offered to the younger, more viable person, which probably will be benefited by a set of double lungs, which will give him more lung function. And there is a small advantage in survival when you go many years after transplant when you are recipient of a double lung versus a single lung. If you see here the tendency over the last few years for alpha-1 antitrypsin deficiency, according to this same registry we talked about before, by far today most people receive double lungs. In COPD, more and more double lungs have been used. Pulmonary fibrosis has classically been a disease in which a single lung transplant is offered, but again, this indication is climbing. And with pulmonary hypertension for a long time, typically you will offer also a double lung transplant. The lung allocation score is a very specific number that will be assigned to you when you get listed, and that score will be derived from the combination of all these numbers, which are supposed to reflect how sick you are. Now, here, a patient with pulmonary fibrosis with all these characteristics, being hypoxic, requiring 6 liters of oxygen, having a little bit of retention of carbon dioxide, with diagnosis of pulmonary fibrosis, which is not a diabetic and still walks 450 feet in 6 minutes and has normal kidney function, he will get a score of about 48. If you keep everything the same, but the diagnosis is COPD, that score will be only 34. Why is that? Because the diagnosis of fibrosis carries more weight. Why is that? Because that disease progresses much faster, so it will kill you faster on the transplant list. So that's the group that gets a little bit of an advantage, if you will, in scoring. And again, this is going to be discussed in much more detail later, so I'm not going to spend much time on this. Suffice to say that this is a summation of 270 transplants that we have performed, and you can see that the average waiting time for our patients with COPD is certainly quite a few months, about a year in average, when our pulmonary fibrosis patients will have a waiting time that in average is less than 3 months. Okay, let's go to the next set of preparation. Let's say you were accepted for transplant. You need to prepare. What are you going to do during that waiting time that might be as long as a year? If you were not accepted for transplant and you strongly believe that you should be transplanted, you should take all the information of the transplant workup and get second opinions from other centers. Not every center has the same criteria to accept or deny a case. You may have centers that can do cases that other centers may not be doing for various reasons. So if you are declined your option of transplant and you feel that the option should be given or offered to you, you can seek second opinions. But once you are accepted for transplant, there are a lot of things you need to know. For instance, the prognosis will depend on many factors. You can see here that the mortality rate starts going up. The chances of mortality go up as you get older. And actually, that curve goes quite high after age 65 and certainly very high after age 70. So many centers will have a cutoff age, and that varies from center to center. But the undeniable fact is, the older you are at the time of transplant, that compromises your survival. So the first thing you need to do is to get younger. The other thing that is good for you to know is what volume of transplants is your center doing, because there are many studies that show that centers that have very small volumes will have higher mortality. The centers that do more volume will have lower mortality. And there are several studies that are pointing that out. From the National Registry, you have all these hundreds of centers. You will notice that most centers will do less than 20 transplants a year. Actually, 75% of the centers will do that. And it's only about 25% of the centers that do more than 20 or 30 transplants a year. But if you are in a transplant center that has larger volume, your chances of survival are better than if your transplant center does very little volume. Now, I must say, there are some centers with very small volumes that are outstanding. So I'm not here, this is just a guideline. I'm not trying to criticize any particular program or not. Now, weight has a lot to do with survival. Too little weight or excessive weight have to do with mortality. And you will find that most centers will have some kind of goals that you should achieve. When I meant you should try to get younger, I truly meant it. Because if you think how much you weigh today compared to how much you weighed when you were 18 years old, well, probably there are a few pounds of difference. Well, if somehow you can get down to that weight, your body will be behaving with a better prognosis than if you walk into transplant either overweight and certainly obese. And in fact, if you're too obese, the center will not even take your case. And there are many studies today showing that indeed, the trimmer you get prior transplant, the better you will do. So, when you are in that waiting time, a lot of the time is used to get the people educated in nutrition and doing a lot of rehab. You will hear a conference tomorrow about how important is exercise to just make your disease better. It is very important. And if you want to survive a transplant, the better your nutrition and the better your conditioning, the better you are going to do after transplant. So the transplant waiting time is an opportunity to improve your chances, to get stronger and to get better, to know your medications, start learning the medications you're going to use after transplant. That will be vital for you to survive. And in fact, we do a lot of teaching. We spend a lot of time teaching the right amount of medications. We teach them ahead of time what to expect with the new medications. All this is part of what it will be the difference between success and failure. Then there is the issue of caregiver. You need a very good caregiver. You cannot walk this path alone. It's too tough to walk it alone. You need a caregiver to be there for you. You need a caregiver to be there with you to pay attention when they are telling you everything about medications and prognosis and this and that, because when you're sick, sometimes you don't get the whole message. You need a second set of ears. You need somebody there to keep you warm when you are feeling sick and you're feeling down. You need somebody really care for you and look after you. You need somebody to give you a big hug when you actually need one. It's not an easy job to be a caregiver. It's really tough because you have to be nice, you have to be tender, and yet you have to be capable to stimulate this potential candidate to soar like an eagle. And you have that caregiver in your back telling you that, yes, you can do this and you are going to survive and you're going to do well. I cannot emphasize enough how important the role of the caregiver is. And then there is attitude. I have seen a lot of patients during my years in transplant that have died because of the wrong attitude. The whiners. Everything is a problem. Everything is an obstacle. Everything is yes, but. That people just does not survive. And I have seen, by the same way, people that you could not believe that they will survive such great challenges, and yet they will not waver. They will not allow themselves to be beaten. You have to use the waiting time to create that positive attitude of success. If you don't, you won't succeed. And just to quote the Eagles, so often it happens, we all live our life in chains and we never even know that we did have the key. And that you have to really, truly learn that when you're waiting for a long transplant. And finally, there will come the day that, and typically when you less expect it, on a long weekend, on a Sunday at 3 o'clock in the morning, somebody will tell you that maybe your transplant is going to happen. And that's because somebody in a time of tremendous pain, when a loved one is brain dead, has the presence of mind to allow those organs to be given for donation. One of the most unbelievable gifts that makes us really human, the gift of life, in this case lungs. What's the process? Well, there is a process that is going to happen. Typically, the organ procurement organization is going to let the transplant centers know that there is a donor available, and they will be let known by the order of the lung allocation score. And this donor availability will be followed by the center receiving all the necessary information, laboratories, chest x-rays. They send us the x-rays now via the iPhones, but we take or deny this donor based on that preliminary phone information. The recipient center has not yet seen the donor, but you have to accept it with that information. And if the donor looks and sounds good by the information the transplant center receives, it will be accepted for you. And that's when the recipient will be called, and you will be told, you know what? There is a potential donor for you. You better come on down. And you come down to the center, and you will be admitted. And in that admission, you will be prepared. IV lines will be put on you, and labs will be done, and chest x-ray will be done. And the team will tell you what they know about the donor. Some donors are pristine and straightforward. Some donors are usable, but they may have issues that you have to work around. They call those extended donors. If you are extremely sick and you cannot afford to wait very long, likely is that the donor may not necessarily be perfect. But you may need to accept that. All that discussion will go on. Then the transplant team is allowed to travel to where the donor is, and one of the surgeons of the transplant center will actually evaluate the donor, and the final call comes when the surgeon opens the donor and can actually inspect those lungs. And then if the lungs are good, he calls back and says, everything is good, this is a go. And that's when the recipient goes to the OR, and from there on the surgery will take place. But sometimes, at the very last minute, something will be found wrong with the donor. And you have to be, the recipient has to be mentally ready that he could go through all this drill and nothing may necessarily happen that day. We call that a dry run or a training run. It has a purpose because the next time that recipient is called, he will know what to expect. But those are the things that can happen the day of your transplant. And if you did everything right and you prepare well, no matter how sick and how difficult the situation is, you're going to go through the transplant and you're going to overcome the obstacles and you're going to come out of it and you're going to be having all that positive attitude to prepare for how to live after transplant. But that's a whole other chapter. And then the gods will smile at you and you're ready to move on with new challenges. And that's what I had to you. Thank you.
I don't think the other folks have started coming in quite yet, so if you want to take a question or so for maybe just a minute, are there any questions?
Yes.
Caregiver. You talked about a caregiver. Can it be also a group of person, or does it have to be a one person that is assigned for a caregiver?
More often than not, it tends to be one person. But we have had some patients that we had transplanted where the caregivers were by committee. I.e., a son will come for 2 weeks, and then a daughter will come for another few weeks. Typically, all that has to be arranged in that pre-transplant time. What works the best is the smaller the number, the better it works, because otherwise you introduce so much variability to a situation that is already complex that not always works well. More often than not, most patients that we transplant, they will have a one or maybe at the most two defined caregivers.
And is that part of the point system? Is that
the score system? No, the availability of caregiver plays a role in the decision-making process of the transplant center, but it has no role or bearing in the lung allocation score.
Thank you.
Yeah.
You mentioned osteoporosis and reflux. Are those two things, will they disqualify you for transplant?
There are certain situations that we find when we evaluate potential recipients that will be absolute contraindications. Let's say sometimes we have patients that come in and they've been smokers, and you do a cardiac cath and you find 4 coronary arteries are just about 90% occluded, and there is no room to do a CABG or stents. Well, that will disqualify them absolutely for transplant. Sometimes you find a hidden malignancy that you did not know you have. A polyp in your colon turned out to be malignant. We have had patients that when we did the mammogram, we found something. That will be an absolute contraindication. Absolute contraindications will also be situations like HIV or hepatitis or things of that nature. But then it comes all these other things. The transplant will work the best if you will come to the table with just terrible lungs, but everything else perfect. But that's really not the case. More often than not, you get the person that is a little bit heavy, maybe a touch of diabetes here, one coronary is not great, and may have osteoporosis, etc., etc., etc. Osteoporosis alone seldom will be an absolute contraindication. There are cases of osteoporosis that may be so brutally advanced with fractures and so forth and so on that may be the deal breaker. But osteoporosis, diabetes, and all of those conditions typically will be more the summation of small problems. There are patients that will not be accepted, not because one single issue was terrible, it's just that they have 15 issues that were bad enough that the summation of them all makes you believe that they will not have a good prognosis. So that's where osteoporosis falls into.